exam problem, screening problem, UT problem, some stress will be there. Once you get that stress, once the stressors is there, now in this lung, the TB bacilli will get the cons focus, the cons lesion, the cons complex, they get reactivated. And once they open their eyes, they will go to the top, to the apex, to make a cavitation. Now, once they go to the apex to make a cavitation, this cavitation, you must have heard it in pathology, will have a lot of caseous necrosis, it will have necrotic debris within that, and it will also have a lot of TB bacilli. Now, because it has a lot of TB bacilli, now this patient is able to spread. When they will give cough and the prasad of TB bacilli. So now this TB patient is going to spread, and this TB patient is what we call as secondary tuberculosis. So it is very important for you to know that once the cavitation is formed, this patient is what we call as secondary tuberculosis. Because there are two types of tuberculosis that we need to understand. We can have a primary TB and we can have a secondary TB. The secondary TB is what is also called as a reactivation TB. The secondary TB cases, this is reactivation. It is the key feature, or you can say the main pathologic feature is cavitation. What is cavitation? It is a delayed hypersensitivity response by the body, and with this cavitation, there could be spread of bacilli. There is too much bacilli spread of TB bacilli can happen over here. There is spread of bacilli. Why do you think this cavitation usually happens in the apex? Why did I make it in the apex? Why do you think it is? Is it because of more ventilation or more low perfusion? What do you want to say? Which is the main feature? If it was ventilation, then the cavitation would have been in the upper middle or lower zone. It is always because there is low perfusion. If you want to mark single list answer, it is low perfusion much more important than high. What do you want to say? Spread of TB bacilli can happen over here. There is spread of bacilli. Why do you think this cavitation usually happens in the apex? Why did I make it in the apex? Why do you think it is? Is it because of more ventilation or more low perfusion? What do you want to say? Which is the main feature? If it was ventilation, then the cavitation would have been in the upper middle or lower zone. It is always because there is low perfusion. If you want to mark single list answer, it is low perfusion much more important than high ventilation in the apex, which makes the TB bacilli to make that ventilation. Then the cavitation would have been in the upper middle or lower zone. It is always because there is low perfusion. If you want to mark single list answer, it is low perfusion much more important than high ventilation in the apex, which makes the TB bacilli to make cavitations in the apical part of the lung. And that is what we call as secondary TB. So what are you going to treat? Will you treat the primary TB? No. Will you treat the LTB? No. Will you treat the progressive primary? Yes. And will you treat the secondary TB? Common sense? Yes. Now these secondary TB, why do you treat them? Why do you need to treat them? These secondary TB cases, we need to treat them. Why? Because what if you don't treat them? They will keep on spreading TB bacilli. And what if the immune status of that person is very low? So now there will be cavitations all through the body. There could be all through the organ, all through the lungs. There could be severe form of tuberculosis. We call it as a miliary tuberculosis. Or this patient could even land up into something called as cryptic miliary tuberculosis, where the immune status of the patient is so low that they could not even form the cavitations. Or this may spread to other organs. It is called as disseminated tuberculosis. So the secondary TB should be treated because one is it is a public health problem. Second is that the patient is going to land up into too many complications. Do you know if you do not treat one TB case? Do you know that if you do not treat one TB case, if it is left as untreated, how many new TB cases they can make? They will make 10 to 15 individuals as more TB in 1 year. So that means if you do not treat TB next year, you will get 10 to 15 times more. In 1 year, in year 2022, do you know how many TB cases get Government of India diagnosed? We diagnosed 24.5 lakh TB cases in 1 year in And if we do not treat them, they will come to 10 to 15 times more. We are very happy with our notification rate. Why? Because the more TB you diagnose, the more TB you will treat. And once the more TB you will treat, the lesser chances that next time somebody is going to get TB. So in forthcoming years, the TB has to show a declining trend. But to show it a declining trend, we have to start diagnosing it much more in advance. So anyways, that was the basic pathophysiology of tuberculosis. Now coming over to the next section, that what are the diagnostic modalities in tuberculosis? Please note, I'm not discussing right now what are the diagnostic algorithm as per the National TB Elimination Program. We're right now discussing the availability of what all investigations are available to diagnose tuberculosis from microbiological aspect. A little bit about microbiology. So there are different types of microbiological tests which are available to diagnose and to confirm and to screen for tuberculosis. We can have as sputum testing or genotypic testing, that is the rapid molecular test, or the culture methods, or the phenotypic molecular test, or we can have as the serological test like the IGRA antigen antibody test, the tuberculin sensitivity, and the chest X-ray. Talking about each of them. Talking firstly about the sputum investigation. Please note that the sputum testing, it is taken as a very high sensitivity and kind of a high specificity. If you get single best answer, it is more sensitive, less specific, but it is the investigation of choice for screening of tuberculosis. It is investigation of choice for screening of tuberculosis in general cases. Please note that for screening of TB in HIV, in HIV cases, sputum is not used. In HIV cases, the answer will be CV-NAT. We are very soon going to see how does it happen, CV-NAT. But please note if the MCQ says screening in general situations, answer is sputum testing. This sputum testing, what do you do in sputum testing? What are you checking in sputum? You are checking the acid-fast bacilli. The acid-fast bacilli, they are present because of the mycolic acid, and the acid-fast bacilli will be red color. The bacilli will be red color on the background of a blue color. Background is of a blue color with the bacilli will be of red color. So how do you define the quality of the sputum testing? The quality of the sputum testing is dependent on how good the quantity of sputum, the timing of the sputum, and also on the way of the sputum. The sputum should always be more than the sputum should be, what do you want to say, spot and morning or morning and spot? Please note it is always 2 samples. Followed by this we have is the morning sample. The spot sample is called as A and the morning sample is called as B sample. The type of the sputum, it could be mucoid sputum, it could also be the purulent sputum, or we can have a mucopurulent type. Test beta any one if positive. is taken as a positive report. Anyone, if it becomes as positive, it is taken as positive report. What is the turnaround time? In fact, there is no turnaround time. It is just called as the reporting time for sputum testing. The reporting time for sputum testing, it should be reported within 24 hours of collection. What are the types of sputum testing? Types of sputum testing would depend primarily on the method of doing or the checking of the sputum sample. We can have something called as conventional microscopy, which uses a stain, that is the ZN stain. We can also have a better type of microscope. These are called as LED microscopy. LED microscopy is more better, like you get is better or more advantageous than the conventional microscopy because they offer brighter light emitting diode microscopy. They also use ZN stain. But the most recent that we can have is the fluorescence microscopy. The fluorescence microscopy will use special stains. These are the rhodamine stain. These are the special stains which are used in fluorescence microscopy. If you get single answer, which one is the best one? It is fluorescence microscopy compared to the LED and the conventional. Government of India, most of the places we are using LED microscope, but yes, in many areas we're still using conventional microscopy. Only in big metropolitan cities and super specialty centers we have these fluorescence microscopy, otherwise they are pretty expensive. So we can have the best type is a fluorescence microscopy is the best type of sputum sample testing. Any one sample out of two is called as tuberculosis. Based on the sputum sample, we can grade the severity scale on a like you can have a zero scale, that is negative, or scanty 1 plus 2 plus 3 plus. See better, whenever we do sputum testing, we check the length. So one length is equal to 2 centimeters, which is equal to 100 high power field. Generally speaking, we take the brightness field and we do the 1000x magnification. In your exam, nobody will ask you about the fluorescence microscopy. You don't need to memorize this. But if you are a UG student and in case you are there in tertiary hospitals or bigger hospitals, games like centers, people can ask you fluorescence microscopy. Right field microscopy is what we use in the general program as well. So when will you say scanty? You check one length of the slide. In one length, if you find less than 10 pascal, it is scanty. More than 10, it is called as 1 plus. Now one length is made up of 100 high power field. In every field, if you find more than 10, it is called as 3 plus. In every field, if you find 1 to 10, it is called as 2 plus. Am I clear on this? So in one high power field, one small high power field, if you find 10 pascal, it is called as 2 plus. More than 10, it is called as 3 plus. If you don't find within one high power field, you go and check the full length. In full length, if you check find less than 10, it is scanty. More than 10, it is 1 plus. Very simple, and this has been asked 2-3 times in your exam. If you don't find AFP, common sense would say answer is negative. Fine. Plus, in every field, if you find less than 10 pascal, it is scanty. More than 10, it is called as 1 plus. Now, one length is made up of 100 high power field. In every field, if you find more than 10, it is called as 3 plus. In every field, if you find 1 to 10, it is called as 2 plus. Am I clear on this? So in one high power field, one small high power field, if you find 10 pascal, it is called as 2 plus. More than 10, it is called as 3 plus. If you don't find within one high field, you go and check the full length. In full length, if you check find less than 10, it is scanty. More than 10, it is 1 plus. Very simple, and this has been asked 2-3 times in your exam. If you don't find AFP, common sense would say answer is a negative sample, that is 0 AFP. Coming over to the next one, what other? In full length, if you check find less than 10, it is scanty. More than 10, it is 1 plus. Very simple, and this has been asked 2-3 times in your exam. If you don't find AFP, common sense would say answer is a negative sample, that is 0 AFP. Coming over to the next one, what are the rapid molecular tests? These rapid molecular tests is what we call as the CBNAT, or we can have as the TrueNAT. TrueNAT. These are the NAT tests. What are NAT tests? These are nucleic acid amplification tests. So cartridge-based nucleic acid amplification, CBNAT. What is the principle which is used by the CBNAT on the PCR technique? It is based on PCR technique. CBNAT, please note, it has very high sensitivity and specificity. It is the investigation of choice for diagnosing and confirmation of tuberculosis. Confirmation and diagnosis, we use CBNAT, which is the investigation of choice for diagnosing. Answer is CBNAT. Please also note that there is something called as universal CBNAT. Universal CBNAT means that all TB patients, all TB cases need to get a CBNAT report done before they get started on treatment. Why? Because CBNAT has a very big advantage. It will tell you what treatment to start. So CBNAT is universal CBNAT. It has to be done in all TB cases. It is the investigation of choice, high sensitivity and high specificity. It is the first line investigation. It is the investigation of choice to detect TB in HIV cases as well. Why? Because in HIV cases, there is a very high chance that the people may be sputum negative. So in sputum negative, then you don't need to do sputum as the first place. But yes, I'm not saying sputum not to be done. Sputum will be done, but which is the investigation of choice? Answer is CBNAT in case of HIV, or even for screening. So next is sometimes examiner may ask you what is the advantage of CBNAT. Why do we talk so much about CBNAT? The distinct advantage of CBNAT is the turnaround time. So when will it give you a report? The report is available for CBNAT within 90 minutes. If you get single best answer, please mark 90 minutes because that is the cycle time for CBNAT machine. But generally speaking, the report is available within 2 hours. If you get single best answer, please mark 90 minutes. What is another disadvantage? Another advantage of CBNAT is it will tell us about the rifampicin status of a person. It will tell you whether the patient is rifampicin sensitive or the patient is rifampicin resistant. Next in line, the examiner may also ask you what is the distinct disadvantage of CBNAT. The distinct disadvantage of CBNAT is that in certain situations, the patient may land up into a false negative report. When will the CBNAT give a false negative report? There is something called as lower limit of detection. The limit of detection for CBNAT, limit of detection, that is LOD, limit of detection for CBNAT is less than 130 colony-forming units per ml of the sample. So if 1 ml of whatever ml of the sample, if that ml of the sample has less than 130 colony-forming units for microbacterial TB, then the CBNAT will not be able to pick that up. So this is called as the lower limit of detection, and if it is less, so in low TB, CBNAT not very nice. So another disadvantage of CBNAT could be that there could be high false positivity rate. When will the patient or the person or the investigation may land up into high false positivity, specifically in cases of recent infections, or in cases of repeat or recurrent infections. Now this patient may not be able to give you a true false positive. This investigation may not be able to give you true false positive because it detects what? It detects the dead bacilli also. It may detect the dead bacilli, and therefore you cannot differentiate whether the patient is having a recurrent TB or the patient is having dead bacilli from the previous TB infection. So therefore it is not useful. It is not useful for detecting cases of recurrent TB or recent infections, or also not useful. It is not to be used for cases of follow-ups. It is not used for follow-ups because you won't even come to know like what is happening. For follow-ups, that is the reason I told you in HIV. For follow-ups, you have to do sputum testing. Sputum is very, very important. So in the NAT technology, that is a nucleic acid amplification test. You have already learned about CBNAT. We can also have something called as TrueNAT. TrueNAT is nothing but an Indian version of the CBNAT. TrueNAT was invented, it was made at Molbio Diagnostics. Molbio Diagnostics, which is in Pune. It is in Goa, sorry, not in Pune. So it is in Goa. And this is Indian version of the CBNAT. The main advantage of TrueNAT is that the turnaround time, the reporting time for TrueNAT is even shorter. It gives you a report within how much time? Within 1 hour. Generally speaking, the cycle time is 30 to 40 minutes. It gives you a report within 1 hour. Another big advantage of the TrueNAT is the low cost. It is said that CBNAT is roughly 10 times more costly than TrueNAT. Or in other words, TrueNAT is going to give you in lesser time and less money the same result. It is said that there could be reasonably high sensitivity and reasonably high specificity. There's no loss of validity and the effectivity of the test, but yes, it is lower cost and in shorter time. So that's the advantage, and many states have started using the TrueNAT as well. So that was regarding the rapid molecular test. This is the machine for Gene Expert. What is this Gene Expert? Expert starts with an X, not with E. So Gene Expert, what is this machine used for? It is nothing but nucleic acid amplification test. It is CBNAT machine. It is attached to a PC and you get the report from there. Next in line we have is the line probe assay. What is line probe assay? Line probe assay is going to use line probe assays. They are specialized investigations, and these are specialized laboratories where they do line probe assays. Line probe assays, what is the use? It is used to detect the drug sensitivity test. It is more important to detect the drug sensitivity test rather than modality. Line probe assays we can use for first line probe assay, first line LPA, or we can have line LPA. The first line probe assay, FLLPA, it will detect isoniazid drug resistance. This has been asked many times in your exam. It's a 5-star MCQ. Isoniazid drug resistance is detected using the FLLPA. It is called as FLLPA. FLLPA, isoniazid drug resistance. The second line LPA is going to check us for the fluoroquinolones, and also for the second line injectable drugs. Now these second line injectables, this is just important information for you to know that the second line injectable drugs, they have been taken back, they have been withdrawn from the program as second line. They are now taken as alternate or the third line drug. So we don't use them as actually the second line, they have been demoted. So the injectable drugs are almost off the program now, but yes, second line LPA will check us for the fluoroquinolone, the second line LPA, and some other drugs. So what are the drugs which are assessed using the first line and the second line? The first line is going to detect the drug resistance for isoniazid using which two genes? That is the INH-A promoter and the GAPG. MCQ, pharma and following is the most important gene for INH-A resistance. It is most important gene for isoniazid resistance, that is the GAT gene. Now for fluoroquinolones, this has been asked many times in your exam. What is the drug mutation? It is the diary A and the diary B. For the second line injectables, these are named as second line injectables. They are actually not anymore the second line injectable, but anyways, for exam you should know that these are the second line injectables. We can have the amikacin, kanamycin, caprimycin, and what is the gene? The mutation RRSEIS promoter gene. Ethionamide also has the INH-A promoter gene, and these all are checked using the second line LPA line probe assay. The turnaround time for second line probe assay is just 1 to 3 days. It gives you a report within. Is the advantage of the line probe assay. Coming over to the next one regarding the phenotypic methods. These are again two important methods we can have is the caprimycin, and what is the gene? The mutation RRSEIS promoter gene. Ethionamide also has the gene, and these all are checked using the second line LPA line probe assay. The turnaround time for second line probe assay is just 1 to 3 days. It gives you a report within 1 to 3 days. That is the advantage. Anymore the second line injectable, but anyways, for exam you should know that these are the second line injectables. We can have is the amikacin, kanamycin, caprimycin, and what is the gene? The mutation RRSEIS promoter gene. Ethionamide also has the INH-A promoter gene, and these all are checked using the second line LPA line probe assay. The turnaround time for second line probe assay is just 1 to 3 days. It gives you a report within 1 to 3 days. That is the advantage of the line probe assay. Coming over to the next one regarding the phenotypic methods. These are again two important methods we can have is the BACTEC method or the MCHEC method. The BACTEC method, carbon 14 labeled palmitic acid assay. Immunoassay. So it is C14 palmitic acid immunoassay. It basically will detect what? It will detect the carbon dioxide release by the mycobacterium TB. So whatever mycobacterium is there, how much carbon dioxide they release, that is being checked by the BACTEC method. So don't you think it will tell you about dead or the live or the both? What do you want to say? It is only detecting the live bacilli. On the same principle we have is the MCHEC method. On the same principle we have is the MCHEC method. The MCHEC method is going to detect the oxygen consumption by live bacilli. Common sense, the live bacilli is the only bacilli which is going to consume oxygen. So it is going to tell you about the oxygen consumption by the live bacilli. It is considered to be slightly more sensitive and more specific compared to the BACTEC method. So generally we are using the MCHEC method instead of the BACTEC method. So but yes, please note that they both are going to test for the live bacilli. The phenotypic methods, the BACTEC and the MCHEC method, they are predominantly used for operations. They are used for research methods, and they are used as alternate diagnostic methods. Wherever the patient, you feel that it is TB and the patient is not showing sputum, not showing CBNAT, in those cases we might do MCHEC or BACTEC method, but they are not taken as a routine used test under the national program. Coming over to the next one about culture techniques, we can have two types of culture. In fact, we can have a third type of culture. These are the agar-based culture. The agar-based culture are not used anymore. We can have the solid culture or the liquid culture. The solid culture is based on the media, that is the LJ media. What is the LJ media? We can have two. It's TB and the patient is not showing sputum, not showing CBNAT. So generally we are using the MCHEC method instead of the BACTEC method. So but yes, please note that they both are going to test for the live bacilli. The phenotypic methods, the BACTEC and the MCHEC method, they are predominantly used for operations. They are used for research methods, and they are used as alternate diagnostic methods. Wherever the patient, you feel that it is TB and the patient is not showing sputum, not showing CBNAT, in those cases we might do MCHEC or BACTEC method, but they are not taken as a routine used test under the national program. Coming on, wherever considered to be slightly more sensitive and more specific compared to the BACTEC method. So generally we are using the MCHEC method instead of the BACTEC method. So but yes, please note that they both are going to test for the live bacilli. The phenotypic methods, the BACTEC and the MCHEC method, they are predominantly used for operations. They are used for research methods, and they are used as alternate diagnostic methods. Wherever the patient, you feel that it is TB and the patient is not showing sputum, not showing CBNAT, in those cases we might do MCHEC or BACTEC method, but they are not taken as a routine used test under the national program. Coming over to the next one about culture techniques, we can have two types of culture. In fact, we can have a third type of culture. These are not used for operations. conditions, they are used for search methods, and they are used as alternate diagnostic methods. Wherever the patient, you feel that it is TB and the patient is not showing sputum, not showing CBNAR, in those cases we might do NGIT or bacterial method, but they are not taken as a routine used test under the national program. Coming on to the next one about culture techniques, we can have two types of culture. In fact, we can have a third type of culture. These are the agar-based culture. The agar-based culture are not used anymore. We can have the solid culture or the liquid culture. The solid culture is based on the media, that is the LJ media. What is the LJ media? It is Lowenstein Jensen media. It is Lowenstein Jensen media. The problem with the LJ media is that it takes a lot of time to get a positive result, 8 to 10 weeks. It may take up to 8 to 10 weeks to get the result. And I don't think that any doctor or any medical professional or physician is going to wait for 2 months to say that I'll tell you what is the TB or not. So generally, what are we using? We're using liquid culture. These are one of the taken as the gold standard confirmatory test. They are the gold standard confirmatory test. In liquid culture, we might use Kirchner media, or we can also use the middle group media, taken as the 8 to 10 weeks to get the result. And I don't think that any doctor or any medical professional or physician is going to wait for 2 months to say that I'll tell you what is the TB or not. So generally, what are we using? We're using liquid culture. These are one of the taken as the gold standard confirmatory test. They are the gold standard confirmatory test. In liquid culture, we might use Kirchner media, or we can also use the middle group based media. So these are the two liquid culture techniques. The advantages for liquid culture, again, we get report within a shorter interval and they are taken as the gold standard. Coming to the serological test, because serology, it is based on some antigen antibody response or some immune response. So what happens is whenever there is TB bacteria infection, TB infection in a person, the person is going to show some immune response. The immune response is by release of the cytokines. What is the cytokine which is released in response to the TB bacillus? It is called as interferon gamma. These are the interferon gamma cytokines. So now this test is going to detect the interferon gamma. This test is called as IGRA test. What is the IGRA test? It is interferon gamma release assay. It is going to check for the release of the cytokine. So the IGRA test, it is, please note, please write it in red capital letters. It is not used for diagnosing of TB anywhere in the world, not even in India. In fact, in India, it is banned to carry the IGRA test. What is the use of IGRA test if it is not used for red capital? This test is called as IGRA test. What is the IGRA test? It is interferon gamma release assay. It is going to check for the release of the cytokine. So the IGRA test, it is, please note, please write it in red capital letters. It is not used for diagnosing of TB anywhere in the world, not even in India. In fact, in India, it is banned to carry the IGRA test. What is the use of IGRA test if it is not used for this? The only and the most important use of IGRA test, it is going to detect for the latent TB. And that is the reason it is not used in India. Why don't we use it in India? Because in India, you already know that 30% of the population is high. Primary TB out of that 5% is going to have latent TB. So that is nothing but overdiagnosis of TB, and in no way you're going to help the patient. What is the use of, who is going to use these IGRA tests? Let us say a person is going immigrating from India to US or to Canada or to UK, Australia. So these countries, these developed worlds where there is very low prevalence and incidence of tuberculosis, they want that people who are immigrating to their country, they should be free of tuberculosis. For them, they check using the IGRA test. So that's the only use of IGRA test, otherwise it is not used. What are the examples of the IGRA test? You can just remember, we can have something called as the quantiferon test, the gold TB test, or the spot test. These are not used in India. They are types of the IGRA test. These are serological tests. Coming to the tuberculin skin test. In tuberculin skin test, it is also known as MCQ, the MON2 test. Please note, it is written as the Montox test, but we don't call it as a Montox test. It is called as MON2 test. This is also called as the Birkwe test. Test. It was discovered by Dr. Von Birkwe, and it is also called as the Birkwe test. In the tuberculin skin test, we use something called as the purified protein derivative. We use the purified protein derivative. Now this PPD, it is of two types. We can have a PPD-S or we can have a PPD-RT23. This PPD-S is the standard PPD, and this is the WHO standard PPD. One tuberculosis unit, one tuberculin unit of the PPD-RT23 is equal to 5 tuberculin units of the PPD-S. In India, what are we using? We are using the PPD-RT23. So PPD-S is used in some other countries. In India, we don't use the PPD-S. In India, we use the one tuberculin unit, PPD-RT23. So how do we do the tuberculin skin test in India, also called as the MON2 test? We will take one tuberculin unit, PPD-23, RT23 with tween 80. Now what is this tween 80? With that tween 80, it is nothing but a detergent. What is the use of the detergent? It stabilizes this purified protein derivative and does not allow it to stick to the vessels or to stick to the side walls of the wire. So one tuberculin unit, PPD-RT23, it is given as 0.1 ml. This is put in the mid part of the forearm. And when you read the reaction, once you insert 0.1 ml, there will be a flare over there, the rising of the skin, and then you are going to read the result within 48 to 96 hours. The ideal time to read the result is 72 hours. That is the ideal time to read the result. So based on this, the person may be showing a tuberculin skin test positive, or the person may show a tuberculin skin test negative. So how do you divide whether the patient is showing tuberculin skin test positive or negative? If the patient is having a field reaction of more than 15% and the patient is having no risk factor, in these cases we call it as a tuberculin skin test TST positive. So this is called as TST positive. That means there was some S. In India, what are we using? We are using the PPD-RT23. So PPD-S is used in some other countries. In India, we don't use the PPD-S. In India, we use the one tuberculin unit, PPD-RT23. So how do we? It was discovered by Dr. Von Birkwe, and it is also called as a Birkwe test. In the tuberculin skin test, we use something called as the purified protein derivative. We use the purified protein derivative. PPD, it is of two types. We can have a PPD-S or we can have a PPD-RT23. This PPD-S is the standard PPD, and this is the WHO standard PPD. One tuberculosis unit, one tuberculin unit of the PPD-RT23 is equal to 5 tuberculin units of the PPD-S. In India, what are we using? We are using the PPD-RT23. So PPD-S is used in some other countries. In India, we don't use the PPD-S. In India, we use the one tuberculin unit, PPD PPD RT23. So how do we do the tuberculin skin test? In India, also called as the Montu test in India, DR. In the tuberculin skin test, we use something called as the purified protein derivative. We use the purified protein derivative. Now this PPD, it is of two types. We can have a PPD-S or we can have a PPD-RT23. This PPD-S is the standard PPD and this is the WHO standard PPD. One tuberculosis unit, one tuberculin unit of the PPD-RT23 is equal to 5 tuberculin units of the PPD-S. In India, what are we using? We are using the PPD-RT23. So PPD-S is used in some other countries. In India, we don't use the PPD-S. In India, we use the one tuberculin unit, PPD-RT23. So how do we do the tuberculin skin test in India, also called as the Montu test in India? We will take one tuberculin unit, PPD-23, RT23 with tween 80. Now what is this tween 80? With that tween 80, it is nothing but a detergent. What is the use of the detergent? It stabilizes this purified protein derivative and does not allow it to stick to the vessels or to stick to the side walls of the wine. So one tuberculin unit, PPD-RT23, it is given as 0.1 ml and this is put in the mid part of the forearm. And when you read the reaction, once you insert 0.1 ml, there will be a small bleed over there, flare over there, the rising of the skin, and then you are going to read the result within 48 to 96 hours. The ideal time to read the result is 72 hours. That is the ideal time to read the result. So based on this, the person may be showing a tuberculin skin test positive or the person may show a tuberculin skin test negative. So how do you divide whether the patient is showing tuberculin skin test positive or negative? If the patient is having a reaction of more than 15% and the patient is having this factor, in these cases we call it as a tuberculin skin test TST positive. Okay, so this is called as TST positive. That means there was some present in that person. In case the person is taken for recent imitation or intravenous drug abuse or the age is less than 4 years, adults from high groups, prison cells, healthcare workers, doctor, nurses, in those cases, if the reaction is more than 10 mm, also we take as TB positive. In case of severe immunosuppression or the person has history of TB, in those cases, even if it is more than 5 mm, we take it as positive. So that's how it as TST positive or negative. Please note that TST does not mean that the patient has TB. It just means that the person is susceptible to TB or currently may have some infection of TB inside the body. We cannot guarantee whether the patient is yes TB or no TB. So that is what is the tuberculin skin test. There is also another funda that we can do a two-step testing. Two-step TST. What is this two-step TST? It is done in cases where you definitely want to check for the tuberculin. Level tuberculin sensitivity, and the patient is having more. The use of the detergent, it stabilizes this purified protein derivative and does not allow it to stick to the vessels or to stick. So one tuberculin unit, PPD-RT23, it is given as 0.1 ml and this is put in the mid part of the forearm. And when you read the reaction, once you insert 0.1 ml, there will be a small bleed over there, flare over there, the rising of the skin, and then you are going to read the result within 48 to 96 hours. The ideal time to read the result is 72 hours. That is the ideal read the result. So based on this, the person may be showing a tuberculin skin test positive or the person may show a tuberculin skin test negative. So how do you divide whether the patient is showing tuberculin skin test positive or negative? If the patient is having a reaction of more than 15% and the patient is having no risk factor, in these cases we call it as a tuberculin skin test TST positive. Okay, so this is called as TST positive. That means there was some antigen present in that person. In case the person is taken for recent imitation or intravenous drug abuse or the age is less than 4 years, adults from high risk population, high risk groups, prison cells, healthcare workers, doctor, nurses, in those cases, if the reaction of more than 15% and the patient is having no risk factor, in these cases we call it as a tuberculin skin test TST positive. Okay, so this is called as TST positive. That means there was some antigen present in that person. In case the person is taken for recent imitation or intravenous drug abuse or the age is less than 4 years, adults from high risk population, high risk groups, prison cells, healthcare workers, doctor, nurses, in those cases, if the reaction is more than 10 mm, also we take as TB positive. And in case of severe immunosuppression or the person has history of TB, in those cases, even if it is more than 5 mm, we take it as positive. So that's how we declare it as TST positive or negative. Please note that TST does not mean that the patient has TB. It just means that the person is susceptible to TB or currently may have some infection of TB inside the body. We cannot guarantee whether the patient is yes TB or no TB. So that is what is the tuberculin skin test. There is also another funda that we can do a two-step testing. Two-step TST. What is this two-step TST? It is done in cases where you definitely want to check for the tuberculin level, tuberculin sensitivity level in the body. So let us say that you do an initial test and the initial test comes out as negative. Now later on you can repeat the test. In certain situations you can repeat the test. MCQ which is asked is only one. When will you repeat the TST? It has to be done after 3 weeks. Within 3 weeks you will not find it. After 3 weeks we can repeat this test. It is called as two-step testing. Please, you should be cautious on this. That if you do it within 2 to 3 weeks or if the TST is done repeatedly, then there is something called as desensitization mechanism that the patient will have no effect of the tuberculin test will be shown. Common sense, right? The patient is desensitized. So the two-step procedure can only be done in certain situations. So that was a quick review about all the investigations which we have for diagnosing tuberculosis. Now I'm going to share with you what are the investigations which are actually used by the National TB Elimination Program. In our program, that is the NTP, we use first and foremost fruit testing. It is the most important screening test investigation of choice in the situation. Please note that chest X-ray, it is a non-sensitive and a non-specific investigation. It is only used as alternate testing method. It is not into the mainstream. Chest X-ray, we don't depend on the chest X-ray. We do chest X-ray, but that is just taken for follow-ups and for documentation. The main one is sputum testing. It is the investigation of choice. Second test that we use, one is sputum. Second that we use is the expert microbacterium TB, that is the CV NAT. The CV NAT is used. The third we can also use is the TrueNAT from the Monbiot Diagnostics. Fourth that we use is the line probe assay. We already talked on this. Line probe assay could be FLLPA, or we can have as the second line probe assay. And fifth is the culture technique. Please note that the culture that we use under the program is a liquid culture that we use, and this is taken as the gold standard for confirmation of tuberculosis in cases where we are not able to use the sputum or the CBNAT is not showing positive results. And finally, just to close off this topic, what is the turnaround time? Please note that the turnaround time for solid culture, which is not used in the program, it is roughly ranging from 1 month to 2 to 3 months. So it takes a lot of time, 1 to 2 months it takes to get a positive report or a negative report from the culture, solid culture, hence it is not used in the program. In the program, we are using liquid culture, which gives us report within 1 to 6 weeks, 1 week in case of sputum positive samples and 2 to 6 weeks in cases of sputum negative samples. Using the molecular test, we can have as the line probe assays, which give us report within very short time, 1 to 3 days. Generally speaking, the report is generated within 48 hours. The CBNAT, which gives us report within 2 hours, and TrueNAT within 1 hour. And rapid identification of the test using these antigen antibody tests, it is also not done in the program. And with that, thank you so much for watching this whole module about introduction and TB epidemiology. See you in the next one where we discuss about the diagnostic and the management guideline for national TB elimination program. Hi friends, and welcome back to the part 2 of the understanding about the tuberculosis and national TB elimination program. TB, as we all know, it is such a disease because there is more drug resistance. The more drugs we get, the more TB changes, and because more TB changes, we have to change our drugs back again and drugs the guidelines change. And common sense, because the guidelines change, there are definitely 7 to 10 star MCQ point more MCQs you get from this program, national TB elimination program. In this video section, we will probably going to classify it into 2 parts. First section, this section we will talk about the targets, the diagnostic and the management guidelines of the national TB elimination program. In the next video section, I will talk about the organization, other strategies.